But that's the way the software was. And in terms of the number of algorithms, what we were talking about is that there's an algorithm for this section. There's an algorithm for this section when the sugar's up here. There's an algorithm when the sugars are in here that's different from when it's in here. There's an algorithm here, there's an algorithm here. Then there's these algorithms of calculating how much is on board. Then the algorithm of sugars going down or going up in here and other places. So we were identifying where we had different control algorithms in different segments of the control curve. And there's where we've got up to higher numbers of algorithms. It's all part of one big algorithm, but it's all in small sections. And the FDA requires that when you build these devices like this in the future, that each one has to stand alone. That you have to be able to have input. You divide a box around it. Say, well, here's the data that comes in, and this is the data out. And this little box has to be perfect. If this data coming in is bad, whatever comes out has to be corrected. Or a signal, somehow having a signal saying you got bad data and not do anything. You can't let bad data lead to more bad data, which then leads to bad insulin doses, or in your case, bad oxygen doses. So you have to have isolated subroutines that you double check everything. And when things don't make sense, you have to think through, what are my options? And make sure you pick the right options in terms of either alerts to the nurse or the care, we'll call it the caregiver instead of the nurse. Because it might be that they need to readjust this oxygen, or they may need to reconnect the hose on the wall, because there's just lots of places that will break down. And then the FDA often requires that you do an analysis when software intervenes with humans. The FDA requires that you do an analysis, a complete analysis of where all the breakdowns could occur. You basically go through the flow pattern of everything that can't happen and assume that it will happen at one time. And that means the tank at the hospital running out. That means the disconnect at the wall. It means somebody hooking up CO2 instead of O2. That's not good, is it?
Be bad.
I think that could kill you, actually. And you don't think about CO2. We're doing CO2, bicarbonate, and our company down in Austin is making the bicarbonate for us. And CO2 will kill you if it gets high enough, and you don't know it. You just fall asleep and die. And so you have to go through every step of what could go wrong, and then you list the things that causes. Then you list the mitigating things that you've done to mitigate those errors. And you have to think through every one of your subroutines has to go through the same thing. And stand alone. Be able to stand alone in terms of what comes in, what can go wrong with what comes in, and how it's mitigated in your subroutine in terms of the output. And that's time consuming. It makes you very thoughtful as to all the things that go wrong, but also open your eyes to the things that will go wrong, because you think some things would never go wrong, like the oxygen being connected to the wall, or the wire, one of the three plugs. The plug into the machine has three or four connectors. Only having one of them connected. Yeah, things like that. You just have to think all the way through when you're getting ready to use it on humans. Use on humans is very restricted in this country for good reason. What other questions about what we did with our software?
That was a lot of it.
Yeah. Well, one kind of about the humans. How did you start testing the device? So
You want the truth?
Do you want me to turn the camera?
You can't do it that way anymore. Turn the recorder off.
Can't do it that way anymore.
the truth is that I was working on a renal failure prevention project in one of the intensive care units, Joe Cook's unit. And I got there because some sales lady had convinced one of the residents to use what I consider one of the most dangerous drugs in medicine as a medicine to prevent kidney failure, phenolphane. The sales rep was selling it off label.
Figures.
Yeah, she got kicked out last week. I had her kicked out. She's real cute too, but it didn't matter. She left. And we stayed friends because she knew she was wrong. And she was being forced to do it by her sales rep. So she wasn't really mad at me.
It would have been fine for that nowadays. He would have just been kicked out.
Yeah.
Yeah.
Anyway, so the resident was using this renal failure project using what I would consider a dangerous drug. I walked in to see the patient who had developed kidney failure, was about to go on dialysis, and all I did is looked around, I turned the drug off, boop, pressure came up, boop, urine came out, and I walked away, went over to the director of the unit and said, I can stop your renal failure in this unit, but not with that drug. And so I started a little project. So I had a year's worth of data on renal failure, where we used another standard solution and did some education to the anesthesiologist and the nursing staff, and just had an aggressive hydration and some correction of acidosis protocol. We dropped the kidney failure almost by 75%. So I had a database, and the surgeon said, you've done such a good job, would you help me with the diabetes control? And of course, kidney doctors make half their living from treating patients with diabetes. So if I pissed off the endocrinologist, I was going to be in big trouble. So I had to deal with him. You can't tell the endocrinologist that I'm helping. And I did a paper protocol the way everybody else does it, which is to write down, you can't do this with nurses. You can't ask nurses to do sophisticated math. They're people, they're not math people. So I just generated a table. If the sugar's this, you do this, and so forth. And we got the sugars down from 200 post-op day 1 down to the mid-100s. But it really needed to be down in this range. And so I said, the only way to do that is with real control math. And he said, fine, you can do it. And I said, the only way to do that is with a computer. And the nurse would put the sugar in the computer, and the computer would tell her what to do. She'd have to do zero math. And the nurses voted to do it, and I said I'd do it. So I just did it one-on-one for the surgeons using standard techniques. And we got the sugars down pretty well. And one endocrinologist looked over my shoulder and said, you ought to sell this because nobody else is doing it that way. And that's how I got started. But the whole thing was done sort of behind the scene. And then the IRB got a hold of it about 2 years later. They were about ready to cook me, and Joe Cook came to my rescue because he said, he's done, we've dropped our infection rate by 70% because our sugars are controlled. The renal failure rate's 75% lower than it used to be. Leave him alone. So we went ahead and then we took the software out of an Excel spreadsheet, put it into, and started doing some of these if, ands, or but things that you have to do to get through the FDA. And that's how we got started. It was a total accident. It was, I had no intention of controlling sugars. I just happened to have training in control math. My PhD is in control math, so I just happened to have had that tucked away in the back pocket years and years and years ago.
How long did it take to get through FDA?
About a year. And it really took a year because we had, my business partner was, he had never done anything in healthcare. I had never tried to do anything. We had no idea what we were doing. We were just blind leading the blind. We had no idea. You could read the regulations, but there's just so many of them. So it just took a while to get things. We had to get a couple of consultants that understood the FDA process and how we had to show them basically what I just sort of outlined, is you have to show all the possible things that can go wrong, and then you have to mitigating factors in the software,